Good evening, everybody. Today's subject seminar is on shock. I think it is an extremely important topic for the people who have just joined, and for people who are already there, it's a good revision. And for people who are taking exam, again, it is not only an examination topic, but I think it is worth revisiting it from time to time to see what is new and also to strengthen your basics. So we'll hand over the mic to Mahati. Okay, Mahati, start. And other thing is, this is where it's not a didactic session. It should be an interactive session. So please stop her and ask questions. And also, Mahati, you can also ask questions to your colleagues. Okay, right. Start.
Yes. Good evening, everyone. This is Mahati, and today's topic is shock. My moderator is Dr. Ravishankar sir. Shock is defined as a state of cellular and tissue hypoxia due to reduced oxygen delivery, increased oxygen consumption, inadequate oxygen utilization, or a combination of these processes. We need to appreciate that our current understanding didn't come overnight. It took almost hundreds of years of experiments and observations to get here. The word shock first appeared in 1743, but it meant the act of collision, not the physiological state. Guthrie gave it its clinical meaning in 1815. Gross defined it in 1872 as a rude unhinging of the machinery of life. It's poetic, but clinically it's less useful. The first real treatment came during the cholera epidemic of 1830, when IV fluids were first used. Though cholera dehydration is not the same as hemorrhagic shock, IV fluids were first used then. Cryle in 1899 introduced BP measurement and changed the surgical practice worldwide. Blalock in 1930 gave us the classification that we still use today, that is hematogenic, neurogenic, vasogenic, cardiogenic, all that. He also described that third space concept, fluid lost into the injured tissues will be unavailable to the circulation. Vickers in 1950 showed us the concept of irreversible shock, like a point of no return beyond which, even if we reinfuse blood, we can't save the patient. Then the modern definition is that inadequate perfusion of the tissue. So my main objectives are pathophysiology, consequences, classification of shock, signs and symptoms, and septic shock in detail, uh, and resuscitation. So before discussing anything further, I would like to briefly revisit the physiological basis of blood pressure regulation. So
Mahati,
the
just a
blood,
minute. Just a minute. Is your projection? Is it very small letters? Is it how it is, or is it what I am seeing? Is it full screen?
yes, sir, it is full screen, but I'm in presenting in tab. Maybe that's why it is showing like that.
Uh, Sanya, are you seeing it as very small letters, or
Yes, sir. It is smaller than usual.
so? Did you not correct it?
I
When you
thought it was only for me. I was thinking, sir. Well,
very small, and we can't read actually if you can't
reading,
follow.
yes.
Mahati,
Sir,
from now
yes, yes, sir.
from now on, the font size, Dr. Lakshman has spoken to you know how to make presentations, and the font size should be adequate so
Yes,
that
sir.
we are able to read it. Here we can't read it at all. Is there anything you can do now?
Mati, in your tab, have you put it as a full screen? You're presenting with the PPT app
Yes,
only,
ma'am, it
no?
is full screen.
No,
It is full
Yes,
screen.
ma'am.
Okay.
but ours, we are. It is not full screen here. We can't actually see anything at all. It's so small letters. Okay, carry on. There is not much you can do now. Are you sure it is full screen?
Yes, sure, it is full screen, sir. I don't know why.
Okay, right, carry on.
Okay. So the blood pressure is determined by cardiac output and systemic vascular resistance. So any surgical condition that such as shock, sepsis, hemorrhage ultimately alters one or both of these components. So cardiac output itself is the product stroke volume and heart rate. Stroke volume is influenced by three factors, that is preload, afterload, and afterload. Preload is mainly affected by blood loss, fluid status, and venous return. Therefore, hypovolemia leads to decreased preload, reduced stroke volume, and hypotension. Afterload is the resistance that heart must overcome to eject blood. It is mostly determined by the systemic vascular resistance. So increased afterload uh, reduces stroke volume, whereas decreased afterload increases stroke volume. Contractility is the intrinsic strength of the heart, that is myocardial contraction, and is affected by factors such as ischemia, sepsis, and all those things. Reduced contractility is seen in cardiogenic shock, will directly decreases the stroke volume. So, in any surgical patient with hemodynamic instability, a systematic evaluation of preload, afterload, and contractility helps guide appropriate management and forms the basis of the treatment. So, the pathophysiology is described at three levels: cellular, microvascular, and systemic. Coming to the cellular level, as perfusion is reduced, cells are deprived of oxygen, which leads to anaerobic metabolism. So lactic acid accumulates, which in turn causes systemic metabolic acidosis. And as glucose is exhausted within the cells, anaerobic respiration ceases, and there is failure of sodium potassium pumps. So in the intracellular organelles and all. Now the intracellular lysosomes release autodigestive enzymes, which eventually leads to cell lysis. When the tissue ischemia occurs, hypoxia and the metabolic acidosis activates the immune and coagulation system, which further result in the generation of oxygen-free radicals. All this leads to the injury of the capillary endothelial cells, which in turn activate the immune and coagulation system. And the damaged endothelial cell becomes leaky and results in the tissue edema. At the systemic level, so the body responds with series of compensatory mechanisms to maintain the perfusion. So we'll discuss each one in detail. So at the cardiac level, where decreased perfusion pressure, preload and afterload decreases, which is sensed by the baroreceptors, leading to increased sympathetic activity, resulting in tachycardia and systemic vasoconstriction to maintain the cardiac output. At the respiratory level, the tissue hypoperfusion leads to anaerobic metabolism and metabolic acidosis, which stimulates and increase in the respiratory rate and minute ventilation, which produces respiratory alkalosis as compensation. And at the renal level, reduced renal perfusion causes a fall in glomerular filtration rate and urine output, which activates the RAS, which is renin-angiotensin-aldosterone system, which further conserves the sodium and water. So at the endocrine level, there is release of hormones such as antidiuretic hormone and cortisol, which further promotes vasoconstriction and fluid retention. So together, these cardiac, respiratory, renal, and endocrine responses act in a coordinated manner to restore the perfusion. But if the underlying cause persists, these mechanisms eventually fail and leading to the decompensated shock. These are the clinical consequences of shock: unresistible shock, ischemia, reperfusion injury, and the multiple organ failure. So unresistible shock, it is the patients who are in profound shock for a prolonged period of time become unresistible. That is, ability of the compensation is lost, leading to reduced cardiac output and reduced response to fluids or any therapy. And peripherally also, the ability to maintain systemic vascular resistance will be lost, further leading to hypotension. So once patient enters the stage, death is inevitable. What happens in ischemia reperfusion injury is during the systemic hypoperfusion period, we already discussed at the cellular level that the cell lysis occurs and the potassium releases into the circulation, which causes the myocardial depression, vasodilatation, and hypotension. So once the normal circulation is restored, All this happens along with the activated components such as the complements, microvascular thrombi. These all will be flushed back into the systemic circulation, causing the injury to the distant organs, which causes acute lung injury, renal injury, liver failure, cerebral edema, all this. So, what can be done in reperfusion syndrome is that we have to reduce the extent and duration of tissue hypoperfusion. Multiple organ failure is defined as two or more failed organ systems. It is currently has a mortality rate of 60%. There is no specific treatment for multiple organ failure per se, but supporting with ventilation, supporting with cardiovascular support and dialysis until the recovery of the all organ functions. So in short, there is initially adequate cardiovascular compensation to
Mahati, stop
maintain
here.
central
Mahati,
blood
stop.
volume.
Stop here. Any
Yes, sir.
questions so far? Any clarifications?
No, sir.
No, sir.
Okay. Okay, carry on.
Yes, sir. So in short, there is initially adequate cardiovascular compensation to maintain central blood volume and preserve the flow to the vital organs such as lungs, heart, and kidneys. Otherwise, the systems become overloaded, leading to progressive renal, respiratory, and all those decompensation, cardiovascular decompensation. It is the decompensated stage of the shock. Shock can be broadly classified into four main types: the hypovolemic, cardiogenic, obstructive, and distributive, based on the underlying mechanism. So each type has a different pathophysiology and clinical presentation. So we'll be discussing each of these in detail. This slide shows the distribution of different types of shock based on incidence. Mostly, the septic shock is the most common overall, which accounts for 51% of cases, and hypovolemic shock accounts for 38%, and dengue shock syndrome accounts for 7%, which is mainly due to plasma leakage. And anaphylactic represents about 4%, and cardiogenic is rare at around 0.4%. This slide
Wait a
illustrates the
minute.
pathophysiology of the
Wait a
hypovolemic
minute.
shock.
Go back to the
Yes,
previous slide. Go back to. Are you sure about this? Because the cardiogenic shock is only 4%, is it? 0.4%. Wait, this
yes, yes,
is
sir.
it
Yes.
in which setting is this? Because I think cardiogenic shock is one of the most common shocks. I thought. In which setting are you talking about?
So this is actually Western setting. So we were also thinking that
Huh?
we thought it will come under at least 1 or 2%, but it's as per the literature in the Western setting, sir.
Because myocardial infarction, cardiogenic shock is quite a common. This one of the common ways of patients going into multi-organ dysfunction and death. So I was surprised that it's only 0.4%. Okay, if the I think it is from the Cleveland Clinic. I don't know which this one article they are quoting, but anyway, let us see if there is any other. Nikita, Ainaz, Samir, all of you look for percentages of all these shocks
Yes,
to
sir.
see if there is any different figures. Okay, right.
So, pathophysiology of hypovolemic shock, which occurs due to reduction in the circulating intravascular volume, which leads to decreased venous return and cardiac output. So, the causes here are hemorrhage, and also there can be non-hemorrhagic causes, which include poor fluid intake or excessive fluid loss, that is dehydration or vomiting, diarrhea, and urinary losses in case of diabetes, evaporation, anything, or third spacing where fluid is lost into the GIT and interstitial spaces, for example, in bowel obstruction or pancreatitis. So, loss of circulating volume reduces venous return to the heart, resulting in decreased preload, resulting in decreased stroke volume, and therefore reduced cardiac output. The body activates compensatory responses which will compensate with tachycardia, vasoconstriction, and activation of the renin-angiotensin-aldosterone system, as we talked about already. So, if untreated, decreased cardiac output leads to tissue hypoxia, anaerobic metabolism, lactic acidosis, eventually organ dysfunction. So, this is a slide showing advanced trauma life support guidelines, dividing shock into 4 classes. So, it is helpful in pointing out the physiological responses to hemorrhagic shock, helps in identifying the blood loss and guiding its treatment. So, the important thing here is blood pressure is preserved until 30% of volume is lost. So, hypotension here is a late sign. In class 1, minimal blood loss. Here, heart rate is normal. Patient may appear well. By class 3, the patient is tachycardic. Their BP has started to drop and they are now confused. Class 4 is a pre-terminal state. So, and the thing here is there are limitations for this. Like people at age extremes, like children are able to compensate with large volume of blood loss. They will only be tachycardic until they reach a point where they can't compensate anymore. So that at that point, they have a rapid clinical decline. Coming to elderly, it is the opposite. They are less equipped to compensate. So they exhibit higher level of shock at a lower volume of blood loss. And also the problem with ATLS is that the classic signs are, in reality, the classic signs are confusing, delayed, and unreliable. So, for example, in trauma patients, the same manifestations can be caused by blood loss as well as traumatic brain injury, all this. And the heart rate is also unreliable because ATLS uses heart rate greater than 100 as a sign of bleeding. But some studies showed that heart rate is neither sensitive nor specific. And the pulse pressure also. Baseline BP is not known in most of the trauma patients. So we can't tell if it's truly narrowed or not. So BP is only theoretically drops in class 3 shock. By then, the patient has already lost 30 to 40% of blood volume. It's already late. So we need to look beyond the vitals, use a combination of clinical, metabolical, and physiological markers. This slide demonstrates the pathophysiology of cardiogenic shock, which occurs due to failure of the heart to pump effectively, despite having the adequate volume, intravascular volume. So, cardiogenic shock occurs due to uh, myocardial infarction, like impaired contractility, dysarrhythmias, valvular heart disease, anything. So, the impaired myocardium results in reduced stroke volume and reduced cardiac output. Because the heart cannot pump effectively, blood backs up into the pulmonary circulation, which leads to increased pulmonary capillary pressure. So this will lead to pulmonary edema and impaired oxygenation. Ultimately, this all leads to reduced tissue perfusion and organ dysfunction. So we need to address the primary etiology for the definitive management. Obstructive shock occurs due to mechanical obstruction to cardiac filling or outflow, resulting in cardiac output decrease. So conditions in which we see this are cardiac tamponade, tension pneumothorax, massive pulmonary embolism, and like that. Obstruction prevents adequate venous return to the heart. So this results in reduced stroke volume and cardiac output. Ultimately, this also leading to tissue hypoxia and organ dysfunction. So here also the primary etiology need to be tackled. This slide shows distributive shock, characterized by abnormal distribution of blood flow due to systemic vasodilatation. So the primary abnormality here is loss of vascular tone, which leads to vasodilatation. This results in reduced systemic vascular resistance here. So although total blood volume may be normal here, but vasodilatation causes relative hypovolemia and reduced venous return. So this also ultimately leading to inadequate tissue perfusion. So there are 3 types of distributive shock: septic, anaphylactic, and neurogenic. So we need to be well informed about septic shock. This table summarizes the signs and symptoms across all types of shock. The anaphylactic severe allergic reaction, massive histamine release, causes vasodilatation. So here, because of that vasodilatation, blood pressure drops, but the body compensates with tachycardia and tachypnea. The skin will be flushed, swollen, itchy. The classic allergic picture will be there. And bronchoconstriction here is the dangerous part. So the differentiator here would be the urticaria symptoms and the bronchoconstriction. And coming to the cardiogenic, in cardiogenic, as we talked about, cardiogenic, like the heart can't push the blood forward. So BP drops. The body compensates with tachycardia, but because the blood is backing up, pulmonary edema, jugular venous distension occurs. And the skin here is pale, cool, clammy, because the cardiac output is low. Here, the differentiator would be jugular venous distension and pulmonary edema. Coming to the hypovolemia, hypovolemic shock, classic hemorrhage will be there. Volume is lost, so BP drops, heart rate increases, respiratory rate increases, skin is pale, cool, clammy, because the body is vasoconstricting to maintain the central perfusion. Urine drops because the kidneys aren't perfused enough. And the differentiator here would be weak pulse, and there is no jugular venous distension. So here the differentiator would be that. And coming to the obstructive, something is physically blocking the blood flow here, right? So like cardiac tamponade and all. Here the differentiator would be muffled heart sounds, jugular venous distension, and hypotension, which is called Dex triad. So it would be same as cardiogenic features, but the differentiator would be this. And coming to neurogenic, this is the odd one out. In every other shock, heart rate goes up as compensation. In neurogenic shock, heart rate goes down because the sympathetic nervous system is damaged here. The body can't compensate. No vasoconstriction happens, so skin is warm, flushed, and dry. BP drops, but heart rate doesn't rise to fix it. And coming to septic, it this is the response to infection, immune response to infection. So in early sepsis and late sepsis, in early sepsis, vasodilatation causes warm, flushed skin, bounding pulse will be there, and BP drops, heart rate rises, respiratory rate rises, temperature can go either way, like it can be hypo or hyper. In late septic shock, skin becomes pale and cool. Um, After the routine vital parameters, we assess hemodynamic compromise using the indices like shock index, modified shock index, and perfusion index. So this helps in early detection of the shock and guide the treatment. The shock index is defined as the ratio of heart rate to systolic blood pressure. Normal value of this is 0.5 to 0.7. So value of more than 0.9 suggests significant compromise, circulatory compromise is there. Uh, and then the modified shock index replaces the systolic with mean arterial. So it would be heart rate divided by mean arterial pressure. The values above 1.3 are associated with the increased risk of mortality. And the perfusion index represents the ratio of pulsatile to non-pulsatile blood flow in peripheral tissues, so reflecting the peripheral perfusion. That means the low value indicates vasoconstriction and poor perfusion, which is commonly seen in shock. So together, these indices assess circulatory status, identifying the shock earlier and guiding to treatment. So to summarize, for any hypotensive patient you see in the wards or in the ER, first you check the extremity temperature. If they are warm, you're likely looking at the distributive picture. So if it is cold, you check the JVP then, jugular venous pressure. If it is high, it is either because the heart pump has failed, that is cardiogenic, or obstructive. Finally, if the JVP is low, it points you towards the hypovolemic picture. So the septic shock is a severe and life-threatening subset of sepsis associated with high mortality. According to sepsis 3 definition, sepsis is defined as life-threatening organ dysfunction caused by dysregulated host response to infection. And this organ dysfunction is identified by an increase in SOFA score of 2 or more points I'll discuss SOFA in the next slide. So, septic shock is characterized by persistent hypotension, which requires vasopressor support to maintain a mean arterial pressure of at least 65 mm/Hg and serum lactate level greater than 2 millimole per liter, despite having adequate fluid resuscitation. Common causes would be infections such as pneumonia, intra-abdominal infections, UTIs, urinary tract infections, caused by both gram-negative and gram-positive organisms. And the pathophysiology we already discussed. So clinically, it presents with fever or hypothermia. It can go either ways, and tachycardia, hypotension, altered sensorium, and oliguria. So diagnosis is based on the clinical features along with the lab parameters, including that elevated lactate and evidence of organ dysfunction, which can be shown by SOFA. So, to assess the severity of organ dysfunction in sepsis, septic shock, scoring systems like SOFA score are used. The SOFA is sequential organ failure assessment score. It is used in the ICU setting, which evaluates 6 organ systems, that is respiratory, cardiovascular, renal, and all. Each parameter is assigned a score from 0 to 4. And it assesses, like, for example, respiratory function is assessed using the partial pressure of oxygen or percentage of inspired oxygen, that is FiO2. And the coagulation is assessed by platelet count, liver function by bilirubin levels, cardiovascular status by mean arterial pressure, and so on. So a total score of increase of greater than 2 or more indicates significant organ dysfunction. So it is used in defining sepsis. Whereas QSOFA, that is quick SOFA, it is in non-ICU settings. It has components of respiratory rate, altered mental status, and systolic blood pressure. But in the present 2026 guidelines, surveilling sepsis guidelines, it is now strongly recommended that is NEWS 2 scoring is that is replaced the QSOFA. The NEWS 2 scoring is National Early Warning Score. So in this, parameters are taken like respiratory rate, SpO2 and O2 support, and temperature, systolic BP, blood pressure, heart rate, consciousness, confusion, all these are taken. And there is scoring from 0 to 20 points, and greater than 5 points suspect sepsis. So it needs urgent review. And greater than or equal to 7 points is high risk. It needs ICU admission. And also, there is a new recommendation to screen in ambulance if transport is greater than 1 hour. So this is the surviving sepsis campaigns R1 bundle. So in this, a set of 5 critical actions is to be initiated immediately upon recognition of sepsis or septic shock. And we have to note that not all elements may be completed within the first hour, but must be initiated at least. So coming to the step is to measure lactate level immediately. If the initial lactate is greater than 2 millimole per liter, or what? Because we are measuring lactate because it indicates tissue hypoperfusion even before blood pressure drops. And then the step 2 is obtaining blood cultures as early as possible before giving antibiotics, because it identifies the causative organisms to guide the therapy we are giving. And the third one is administering the antibiotics, because early antibiotics significantly reduce the mortality in sepsis. So the Surviving Sepsis Campaign 2026 told that if the patient is in shock and it is definite, probable or possible sepsis, anything, then administer antibiotics within 1 hour. And the source control can be done within 6 hours ideally. Earlier, more merrier. Like antibiotics within 1 hour are also indicated for definite probable sepsis. And a rapid assessment within 3 hours first and then antibiotics. This is conditional, not mandatory. And the major change in 2026 is prolonged infusion of beta lactams is now a strong recommendation. So some Blink 3 trial data showed 25 fewer deaths per 1,000 patients. And then de-escalation, when culture sensitivities are available, we de-escalate it. And multi-drug resistance coverage. Only give empirically only if patient has specific risk factors. We don't give universally. So also there is no empiric antifungals routinely unless there are high risk features. And there is no empiric anaerobic coverage also unless there are intra-abdominal or gynecological or necrotizing soft tissue source, anything like that. So coming to the step 4, IV fluid, intravenous fluid resuscitation, 30 ml per kg is indicated for hypotension or lactate above more than or equal to 4 millimole per liter because it restores intravascular volume and also restores organ perfusion. Regarding the fluid choice, what should be given is 2026 is telling guidelines is telling that balanced crystalloids like Ringer's lactate are preferred now. Albumin, uh, the meta-analysis all shows that there is no mortality benefit. So it is not routinely recommended, but may be considered in cirrhosis. So before this, traditionally, sepsis guidelines recommended a fixed fluid resuscitation strategy. But in 2026 update, they say it is to be individualized. Like the 30 ml per kg is no longer a mandatory target. It is just an initial guide. And and we have to reassess the hemodynamic response of the patient. Like what we do is we will start initial bolus like 20 or 30 ml per kg, and we will reassess this within minutes, like with mean arterial pressure, urine output, or lactate, and there is also passive leg raise test, uh, echo. So if responsive, we'll continue the fluids. If not, we'll stop the fluids and start vasopressors. This is done because both under resuscitation and fluid overload, both are increasing the mortality. And there is a thing in here, like in patients with a BMI greater than 30, using actual body weight may lead to fluid overload. So, ideal or adjusted body weight is often considered here as a starting point. So, the present guidelines stress more on the identifying fluid responsiveness and avoiding both under resuscitation and fluid overload. So overall sepsis resuscitation has evolved from give 30 ml to kg per kg to all, not that. To we are giving fluids based on individual physiology and individual responses. And there is this thing like liberal versus restrictive fluid strategies in sepsis. 2026 update states that recommendation is now either liberal or restrictive because both are same. Therefore, the choice should be individualized. And the step 5 is vasopressors. Vasopressors are given to maintain the mean arterial pressure at greater than or equal to 65 mmHg. So the first line agent here is norepinephrine because it maintains perfusion. Coming to the vasopressor timing, when to be given. This 2026 suggests that we start with initial fluid bolus first. However, in patients presenting with severe shock, we'll give vasopressor concurrently with the fluids. Another important practical change is regarding the peripheral vasopressors. We should not delay therapy waiting for the central line access. So peripherally also we should start the vasopressors. And the mean arterial pressure target for vasopressor is 65 mmHg. It is strongly recommended. But for the patients aged above or equal to 65 years, 60 to 65 mmHg is also acceptable, which reduces the vasopressor exposure without increasing the mortality. And inotropes can be used in addition to vasopressor, but not instead of them. So this is the treating sepsis according to the latest evidence. Uh, What's recommended is shown in green. So we have talked about it, the antibiotics early administration uh, to continue, and based on the culture and sensitivity results, we de-escalate it. And the fluids also we talked about, the balanced crystalloids we should use. And we have to avoid the starches because there is a risk of acute kidney injury. And also there are high chloride solutions. We have to avoid that because there is a risk of hyperchloremic acidosis. And vasopressors, we talked about, the first line choice is norepinephrine. And dopamine is avoided because there is an increase in arrhythmia risk. And phenylephrine is avoided because there is there is an increase in risk of decreased cardiac output. And we have to start early enteral nutrition. It is preferred over parenteral nutrition. So it is started within the 1 to 2 days. And insulin therapy also, the target blood glucose should be between 140 to 180 because we have to avoid the hypoglycemia. And there is lung protective ventilation if mechanically ventilated. The tidal volume should be 6 ml per kg, and plateau pressure should be less than 30 centimeter of water, and it prevents the ventilator-induced lung injury. And urinary catheter is essential because we have to measure urine output hourly. So monitoring target of urinary output should be greater than or equal to zero 0.5 ml per kg per hour. And then what's not recommended is shown in red color. Deep sedation increases ICU stay, so we avoid that. And goal-oriented therapy is avoided because we are now following the individualized basis. And also molecular targeted therapies are still under investigation. Coming to the management, the resuscitation of shock. Management of hemorrhagic shock is based on systematic resuscitation principles, with the first priority being the rapid control of hemorrhage. This is achieved through direct pressure or application of tourniquet and definitive operative or interventional hemostasis. And simultaneously, intravascular volume is restored by securing two large bore intravenous lines. Uh, and if needed, we also secure intraosseous or central access, followed by administration of crystalloids along with early initiation of blood products and all. And restoration of oxygen carrying capacity it is achieved with PRBC, packed red blood cell transfusion. So then the hemoglobin level should be around 7 to 10 gram per deciliter, along with the supplemental oxygen. Finally, coagulopathy is corrected using a massive transfusion protocol with balanced resuscitation in a 1:1:1 fashion of packed red blood cells, fresh frozen plasma, and platelets. So it avoids dilutional coagulopathy. Overall, the focus is on early hemorrhage control, adequate perfusion, and prevention of the lethal triad. The lethal triad in trauma refers to the combination of hypothermia, acidosis, and coagulopathy, which together form a self-perpetuating cycle, leading to worsening shock and increasing mortality. So the hypothermia is generally defined as a core body temperature less than 35 degrees centigrade and commonly occurs in trauma patients due to exposure, shock, and administration of cold IV fluids or blood products. Even mild hypothermia impairs platelet function and reduces the activity of coagulation enzymes, so thereby contributing to the bleeding, all in a cycling fashion. So we have to treat it with warm fluids, warm environment, and target should be greater than 36. Coming to the acidosis, it is most commonly metabolic acidosis and is defined as blood pH less than 7.35 and results from inadequate tissue perfusion leading to anaerobic metabolism and lactate accumulation. So severe acidosis, particularly when pH falls below 7.2, it depresses the myocardial contractility also, vasodilatation, and further impairs the coagulation cascade. So treating it is nothing but restoring perfusion and bicarbonate if pH is less than 7.1. And we have to treat the underlying cause. Coming to the coagulopathy in trauma, it is multifactorial. It defined clinically by deranged coagulation parameters such as PT, APTT, prolonged prothrombin time, activated partial thromboplastin time, or an elevated INR above 1.5. So it occurs due to loss and consumption of clotting factors during hemorrhage. We have to treat it with 1:1:1, TRBC, FFPs and platelets, cryoprecipitate for fibrinogen, and tranexamic acid early. So coming to damage control resuscitation, it is a strategy aiming at managing severe hemorrhagic shock by prioritizing the early bleeding control and prevention of the leval triad. So it begins with the permissive hypotension or hypotensive resuscitation, where we target a systolic blood pressure at a lower level, around 80 to 90 mmHg, to maintain minimal perfusion while avoiding the disruption of clots, thereby limiting further bleeding won't occur. There is an exception to this. In traumatic brain injury, we target higher pressures in order to maintain cerebral perfusion. Simultaneously, there is a focus on rapid definitive control of bleeding, which may be achieved through emergency surgery or interventional radiology techniques, anything. So fluid administration is restricted and controlled, so in which we avoid excessive crystalloids and early initiation of hemostatic resuscitation. 1:1:1 ratio of PRBC, FFP platelets, and tranexamic acid within 3 hours of trauma to prevent the dilutional coagulopathy. Along with this, the active measures are taken for prevention and treatment of the lethal triad, as we already discussed. So additionally, hypocalcemia. There's a hypocalcemia which can occur due to what we are giving, like the massive transfusion protocol and all. So as it further worsens coagulopathy, we have to tackle hypocalcemia also. So overall, damage control resuscitation is a coordinated approach that integrates all the controlled resuscitation, early hemorrhage control, and correction of physiological derangements, all this. So once we start resuscitation, how do we know it's actually working? So that's what endpoints tell us. Like normalization of vital signs alone is an inadequate endpoint of resuscitation. Tissue level endpoints such as lactate clearance, base deficit, all this should be tackled. So we know that hypoxia leading to anaerobic metabolism, lactic acidosis, all this. So rising lactate indicates tissue distress. So we don't just look at the number, but we also track clearance. Is it coming down by at least 10% every hour? We'll see that. So if yes, resuscitation is working. If lactate stays above 4, it indicates severe shock. Target should be less than 2 millimole per liter. But the catch here is epinephrine also causes lactate resulting in, so in stressed states, lactate can be elevated even without true hypoxia. Coming to base deficit is defined as how many millimoles of base are needed to normalize the pH levels. Normal is 0 to -2. When it goes below -6, that's significant shock. Below -40, that is severe metabolic acidosis. And we should not just see high base deficit and panic, because it can be also caused due to the IV fluids we are giving. Because the base deficit is commonly influenced by the chloride in the IV fluids, which results in hyperchloremic metabolic acidosis. In case of acute renal failure, base deficit of greater than 6 millimole per liter is associated with poor outcome because kidneys can't excrete acid. So here base deficit becomes unreliable. And then coming to the urine output, this is the simplest and accessible marker with bedside. Since kidney is sensitive to perfusion, it is one of the first organs to suffer when blood flow drops. If the patient is making more than 0.5 ml per kg per hour, kidneys are being perfused. If the urine output drops, something is wrong with the circulating volume. Even if the BP is okay, something is wrong with the circulating volume. So mean arterial pressure, it is the average pressure driving the blood to the organs. So systolic BP can be misleading, but the mean arterial pressure gives us the true picture. We target it above 65 mmHg to ensure that vital organs are adequately perfused. But in damaged control resuscitation, we actually accept a lower range, 50 to 60, because in active bleeding, pushing the BP too high can dislodge the clots and worsen hemorrhage. That is what we discussed in permissive hypotension in the before slide. And there are oxygen saturation measurements from central veins. They tell us how much oxygen is left in the blood after tissues have taken what they need. So SCVO2 is from the superior vena cava and SVO2 is from the pulmonary artery. Both reflect the balance between the oxygen delivery and the consumption at the tissue level. It is very useful in ICU settings. Coming to temperature, this one is often overlooked, but it is important, especially in trauma, because hypothermia below 36 degrees disrupts coagulation and the lethal triad all over again. So clotting factors don't work properly in the cold. Platelets come dysfunctional. This leads to the lethal triad and all this. So we have to tackle the temperature also. Even in the damage control surgery, we make sure that the patient is warm. So no single marker is enough on its own. Lactate temperature of kidney perfusion and the mean arterial pressure tells you about pressure, all this. So we have to use them together, and the goal is always to normalize all of them as fast as possible. So this is the study that I found on shock. It is systematic view. So in a surgical or emergency setting, the study is diagnostic accuracy of point of care ultrasound in shock. So in a surgical or emergency setting, if focus indicates a septic shock uh, subtype like tamponade or PE, the probability of that diagnosis being correct is extremely high because the sensitivity is high. The performance of specific etiology shows that cardiac tamponade, it is showing 100% sensitivity in this study. So this concludes that the focus diagnostics to with the pri- pri- in due to there is high shock focused for rapid narrowing of and this
Mahati, your
randomized
Voice is breaking.
suddenly your voice is breaking.
Explain this slide once again, Mahati.
that
Voice was breaking.
Hello, Mahati.
yes ma'am.
Just
This is
change
the
your
study
position a
on
little.
this is study of methylene blue. This slide shows the study on methylene blue for patients with septic shock. So its aim is to assess whether early adjunctive methylene blue can reduce the time to vasopressor discontinuation in septic shock patients. And trial,
Mahati, just change your position. Where are you sitting?
am I audible, sir?
Now you are audible. I think it is going in and out. Till now it was good. I don't know what happened. Where are you sitting? Hello?
Sir, in my hostel only, sir.
Okay. Anyway, are you finished
Sir,
now?
am I audible now, sir?
Yeah.
Am I audible now, sir?
Yeah, yeah.
Hello?
Yes, Mahati.
Yes, yes, you're audible. Just speak about the last slide.
Go back to the last slide.
So this is the study on methylene blue patients with septic shock. It aimed to early methylene blue reduce time to vasopressor continuation in patients with shock. So it is a randomized control trial. It is only single centered, uh, and the primary outcome was the time to vasopressor discontinuation. And there are seconds and days on mechanical ventilator, length of stay, all these. So the conclusion is that in patients with septic shock, methylene blue initiated within 24 hours reduced the time to vasopressor discontinuation and increased vasopressor free days at 28 days. It also reduced the length of stay in ICU and hospital without adverse effects.
So you
How
give
much you will give and how much you will give and how often you have to give and how will you give?
Mahati?
Yes, sir. Sir. Yes, sir.
You didn't see, look at that. It's okay.
So see, the learning is whenever you put something on a slide, you should put
Okay.
it when you know about it.
Okay, sir.
So in the
So,
same setting, my question will be, what is the role of steroid in septic shock? Because you mentioned about lessening the
The
vasopressor,
2020,
this thing. Huh?
yes, sir. Yes, sir. In
Somehow
2026
your voice is
guidelines, they've shown
breaking
that,
completely. Yeah.
ah, yes, Mahati.
sir, in
2026 guidelines.
2026 guidelines, they've shown that corticosteroids usage is only conditional and not strongly recommended. I've read that
Correct.
line, sir.
Correct.
Yeah, conditional. It is only known to lessen the duration of vasopressors, but overall survival, it doesn't add any benefit.
And it's for refractory shock in specific, sir. Like if it is not at all
Yeah,
responding to
correct,
anything else.
correct,
Yeah.
correct.
Then you can give. Yeah, nothing, no harm in giving. Okay, questions, comments? Questions, anybody?
Mahati, how do you assess? You are talking about hemorrhagic shock, no? How do you assess blood loss in the OT to anticipate that patient will go into shock or something? Should know how to assess the blood loss, no? How do you assess it?
Anybody
Hello?
else?
So we count
Ah,
So, so
somebody.
that we
MOPS
use
congestion.
and the
Not
soap
at all audible properly.
Mahati, last bit you are cracking up. I don't know why. Otherwise, till now everything was good. Somebody else,
so
Nikita, tell
we
us
assess
how do you
using the
assess
soaked
the?
mop.
Um, okay,
We assess using the soaked mops, gauze, and blood in suction bottles, sir.
No, when we ask something, like some question like that, no, there are different methods you should tell. One is visual estimation, and then there are techniques like that. You're broadly telling you'll use mops. So mops, how do you assess?
one fully soaked mop. How much will it usually?
like the abdominal mop, which we use for laparotomy.
So 100
So this
ml,
is a question.
sir?
Yeah, correct. Around approximately 100. And see, this is a question which you will get it for 10 marks. So read about it and write it
Yes.
up in the group. There are different methods. One is visual, one is gravimetric method, weight. Along with the mop, you also look at the amount of blood loss by looking at the suction. And then there is capacity estimation. That is what we were talking about. Then there is newer techniques like photometric and computer vision application. So all those things. So that's a main question, 10 marker. Okay.
Good question, Niranjan, I think. So, any questions from students? Then,
No questions in specific, sir. But I think
if there are
new.
no questions, then remarks as to the presentation and as to the coverage of the subject.
She did a very good job, sir. Actually, explained physiology as well as all the newer guidelines in a stepwise manner and in detail of each of them. She gave even examples for all the types of the recommendations and everything. Uh, And it was clear, sir. The only thing is, we are supposed to follow the new guideline. Most of the sepsis cases are being handled by ICUs, but at least we should score. We should use that new score, is what I was thinking, sir,
Yeah.
in our notes.
Sanya,
She did.
Karthik,
She presented well, sir. A very important topic, both the exam point of view as well as the clinic's point of view. Everybody has to know everything. Really very well presented, sir.
Karthik,
So it's a well-presented presentation, sir. Like including the sepsis guideline, the recent sepsis guideline, which we most of them we don't know. Like it was a very nice slide, sir. Very systematically, she explained everything in detail.
Niranjan.
She presented well, sir.
I will go as far as to say this was one of the best presentations I've heard. It was amazing. Mahati, you have really done a fantastic job. I don't think anyone could have said that you are presenting for the first time, and you presented like a veteran. I think even ICU consultants will be very proud the way you presented this. Really good. So you have set the bar high. You have to maintain or improve on this. Next time when you present, it should be equally as good, if not better. Okay. I think the presentation was very good. You didn't read the slides. You this only there was initial problem with the size of the slides, but after that I think it picked up, and your present that coverage of the topic was also very good. So maintain this. I think it was an excellent presentation. Well done. Kudos. Good night.
Thank you, sir. Good night.
Good night, sir.